In this video, I'm discussing about the orbital cellulitis video stations. So normally orbital cellulitis video, what we see that a child who is average for age, a boy or girl, anyone can be. The child may be on hospital setting or outpatient. The child may have no any device or cannula can be present. What we find mainly in the eye, that is swelling of the eye, and if it is severe, not opening the eye, it is going more to the orbital cellulitis. If it is like less swelling than periorbital cellulitis, we keep in DD these two, and also it is unilateral most of the time. Very, very rarely bilateral orbital cellulitis occurs. So it is unilateral. So what are the differential diagnosis of the unilateral eye swelling we can give? First of all, orbital cellulitis, periorbital cellulitis, then conjunctivitis, any trauma to the eye, sting, bite, allergy, anaphylaxis, and eye infection secondary to facial palsy. These are also DD. We can tell nephrotic syndrome, protein energy malnutrition. These are the bilateral eye swelling. Now, what are the history we ask? First, history of the features and the DD we ask, like onset, course, and duration, what increase and what decrease. Is there any diurnal variations? Now, about first eye symptoms, as eye we are seeing, is it red, painful eye movement, affection of the red and green visions, excessive lacrimations, oozing past, any bulging eyes, light intolerance? Is it affecting the upper or lower eyelid or both? Any proptosis or chemosis? So, upper and lower eyelid, that is both eyelid, then it is orbital cellulitis. One eyelid, it is unilateral periorbital. Then any swelling in any other part of the body where it started first, any associated with fever, headache, sign of increased intracranial pressures, any drowsiness, seizure, or abnormal movement. Is it preceded by sinusitis? Any history of any trauma, sting bite, or anaphylaxis? Then any family history of similar conditions, any chronic illness, especially the nephrotic syndrome, diabetes mellitus, immunodeficiency, any drugs he is taking. So the history portion I'm again repeating: onset, course, and durations, what increase or what decrease, any diurnal variation. Now, how symptoms: it is painful or painless, itching, lower or upper both eyelid affected or not, any diurnal variations, any red or green light problem, any uh, then any lacrimation, oozing, pus, bulging of the eye. These are affection of the red and green visions. Now, any swelling in any other part of the body and where it started first, and any associated with fever, headache, sign of increased intracranial pressure, any drowsiness, seizure, or abnormal movements. Is it preceded by any sinusitis, any history of trauma, sting bite, or anaphylaxis, any family history of similar conditions, any chronic illness, especially the mellitus immunodeficiency, and any drug he is taking. Now, what examination we do? Suppose it is an orbital or periorbital cellulitis. So, after involving my consultant, ENT, ophthalmology, neurology, if needed, or neurosurgeons, ABC, airway breathing circulations, vitals, conscious level, general examination for sign of sepsis, eye examination, ENT examination, neurology examination. So as well as ABC, airway breathing circulation, ABC, vital signs, I'll involve my senior pediatricians if needed, neurosurgeon, because orbital cellulitis and emergency conditions. Then we do the eye examination, ENT examinations, neurological examinations. Then investigation, full blood count, CRP, SR as culture sensitivity, then CT scan of the brain, MRI of the brain, CT of the orbit, sinuses, and brain. Other swab from the eye if possible. What is the indication of CT scan? Indication for CT are suspected orbital involvement, central neurological signs, inability to assess the eye movements or visions, bilateral edema, and deterioration despite treatment. And indication for MRI are suspected intracranial involvement on CT. Now, what is the complications of orbital or periorbital cellulitis? So these are, we can divide eye and neurological. Eye like orbital abscess, optic neuritis, orbital abscess, optic neuritis, blindness, exposure keratitis, glaucoma, panophthalmitis. Neurological like cranial nerve palsy, subperiosteal abscess, meningitis, cavernous sinus thrombosis. So eye complications are orbital abscess, optic neuritis, and blindness, exposure keratitis, glaucoma, panophthalmitis. Neurological are cranial nerve palsy, subperiosteal abscess, meningitis, cavernous sinus thrombosis. Management, I will involve the multidisciplinary team, antibiotics and reflex. So multidisciplinary team are my pediatricians. If it is orbital cellulitis going, of course, ENT, neurosurgeons, because it within 4 hours. So periorbital review eye movement and red green color visions PID. So eye movement intact or red green color visions. Then orbital or urgent ophthalmology ENT review within 4 hours for surgical drainage. Intracerebral complications urgent neurological review. So orbital cellulitis, what is the treatment we are offering? Any orbital cellulitis, we start with IV treatment, ceftriaxone or cefotaxime. If toxic, we add the clindamycins. If penicillin anaphylaxis, then we give ciprofloxacin plus clindamycins. If penicillin allergy, we give the clindamycin. If improving, shift to coamoxiclav oral. And duration of the treatment is 21 days and 6 weeks if bone involvement. Again, I am repeating the orbital cellulitis treatment. We are starting with intravenous ceftriaxone or petoxim. If it is anaphylaxis, then ciprofloxacin, clindamycin if toxic, and anaphylaxis, then ciprofloxacin plus clindamycin. Penicillin allergic clindamycin if improving, shift to oral coamoxiclav. And 21 days is the duration of treatment. And if bone involvement, 6 weeks if bone involvement. Now, periorbital cellulitis, if upper eyelid, we give the oral coamoxiclav. Both eyelids severe or no improvement after 48 hours. So we are going IV coamoxiclav. If penicillin allergy, we give the clindamycin. If improving, shift to coamoxiclav oral. Duration of treatment is 14 days. Now, indication for admissions. Indication of admissions are suspected orbital involvement, fever, immunocompromised, no improvement after 48 hours of oral antibiotics, and less than 1 year. Sinusitis. If acute, treat it with amoxicillin only. So if it is sinusitis, amoxicillin only, change to coamoxiclav if no response after 48 hours, IV if severe, and total duration is 7 days. So 2 into 1 days, orbital cellulitis if bone involvement 6 weeks, and periorbital is 14 days. 7 days is sinusitis. Thank you.